Hello everyone and welcome to Rad Chat here live at the SGRT Community Annual Conference, and we're joined by yet another amazing guest. Adi, would you like to introduce yourself?
Yeah, my name is Adi Robinson. I'm a senior medical physicist at Advent Health in Florida.
Tell us a little bit about Advent Health.
So Advent Health is a multi-state non-for-profit hospital. So we are in, I would say 7 to 10 states within the United States, but our hub and the state that we have the most facilities, it is in Florida. So in the Central Florida region, and if you can imagine, Florida is kind of like an upside down boot, Italy style kind of state. In the middle, where Orlando sits, and then Tampa on the west, and then Daytona on the east, we have about 12 facilities. So we're all varying true being kind of facility with trying to be state of the art as much as we can, and that's where integrating with SGRT kind of started a few years ago, and we have been rapidly adding more and more of SGRT related technology to our facilities.
So what does a day in the life look like for you at the moment?
So unfortunately, because of the implementation of technology, we get a rush of patients. So we opened our clinic in Celebration, where I'm at, about 5 years ago, and we went from 0 patients to 60 patients a day within about 8 months.
Wow.
And we've been treating 60 patients a day on one LINAC for about 4 years. And we did order a new, the facilities was built with 2 vaults. One of them sat empty because they didn't really know the volume. The problem is we were ready for a second machine within a year and a half, but then COVID hit, and it was really hard to get new equipment approval and variant to build a new LINAC for us. So that was kind of delayed. So we were kind of working really hard. So we would start our day around 7 a.m., 6:30 a.m., and we would work all the way up to 8, 9. And being the only physicist on site was hard to manage both things. But we were able to do all, in the last year and a half, we were able to commission a new LINAC and install everything that SGRT has involved. So from sim to plan to dose to treat. So all of it was implemented and commissioned and being used, and it's been an amazing ride.
So in your talk, you talked about about treatment planning specifically, and how maybe you've made quite significant changes in the way that you plan radiotherapy now. Can you talk us through that?
Yeah, I think as humans, we get into sort of a routine. So similarly in our professions, all of our planners have, most of them, I think the median years of experience they have is about 15. So they've been doing what they're doing for a long time, and they're pretty good at it. But with that, they're kind of set in their ways. So as new technologies come, it's sometimes hard to convince those people of the benefits that they can reap with it. And we've introduced some auto contouring tools and some auto planning tools that was harder to introduce into that kind of community, because they feel like I can do better than the machine, I can do better than the robot. But we try to tell them it's a tool for you to put in your arsenal to kind of refine or improve your plans. It's not going to replace you. It's here to help you. And similar with the non-coplanar, there's this big fear of, if I plan a non-coplanar plan, it's not going to be deliverable, or it's not going to clear, and then there's going to be a replan and delay, and it's going to be my fault because I planned it. So that stigma needs to go away, and we need to reassure them that we can verify and prevent all dry runs or replans or delays or all those sorts of things, because we have the tools now to see that before we even call the patient to schedule their treatment.
You said non-coplanar. Just for anyone listening who doesn't know what planar or non-coplanar is, how would you explain it?
So traditional plans are set where the patient is when they're laying on the couch at the linear accelerator, the couch doesn't move. It always stays at what we call couch 0. and the gantry of the machine would rotate around them. If you want to get creative, you can rotate the couch off zero, and hence the non-coplanar term, and do a combination of different couch angles and different gantry angles to better off the plan. And that helps you with conforming the beam better to different anatomies, sparing doses to healthy tissue and organs at risk. So that's the benefit of it. But again, the risk, as I mentioned, is the collision to the patient, to the couch, and stuff like that people are scared of.
And how do you account for collision risk problems or worries?
So now with the technology, we have MapRT, which we capture a 3D surface of the patient at sim. So the patient shows up for their pre-treatment simulation for planning purposes. And before we even administer any type of radiation, they lay on the couch in their treatment position, and we capture that 3D rendering of their body, and we place it in a virtual LINAC room where we can test any combination of gantry angles and couch angles that we want, and it will tell us whether we clear or don't clear. And that is once we agree on some sort of a general position, we can scan the patient, and then the planner receives that, and they can use the clearance map plus their planning knowledge to kind of optimize the plan and make it best as we can. I think today I presented a case where we had a breast case where all of our planning constraints have met. So it was a good, clinically deliverable plan. And it was a coplanar, so the couch stayed at zero, but just as a proof of concept, we moved the couch by 15 degrees each direction. So one moved clockwise, one moved counterclockwise, and basically re-optimized the plan with the same calculations, the same kind of optimizers that the previous plan used. And we got a clinically viable plan, but OAR doses were better. So that was kind of a proof of concept for our team, where to show that yes, we're supposed to pass all of our constraints, and all of our planning constraint and checklists should be as best as we can, but we can do better by making small modifications. And our goal is to have zero dose to critical organs, which is impossible, but we want as close to zero at least. So if it's a difference, if both plans pass all of our constraints, but one has way lower dose to, let's say, the lung or the heart, I would want to choose that one over the other one. So that's what we're trying to educate and teach them.
And it was interesting, one of the cases you presented, because you do quite a few prone breast techniques, don't you?
Yes.
And it was interesting from that perspective of how potentially the collision is more likely if you have larger patients with a BMI
Yes.
that's higher.
So prone for us, and we do prone breast and we do prone pelvis, but with the prone breast there's a double kind of worry for us. So females with a larger breast, it hangs lower, so we have to create a bigger buildup for that.
Yeah.
So that raises their back and higher up, so we have to play with the isocenter of the beam and make sure that the gantry can clear as it's rotating. And patients with a larger body also can collide. So we really have to pay attention to it. And that was, I think last year, before we got MapRT, we had about, I would say 5 to 10% of all prone breasts had to be replanned after the patient already came for treatment, because of, on day one, we set them up and we said, I'm sorry, it's just not gonna clear, we're gonna have to readjust, come back next week.
Yeah.
And this year, 2024, it's zero. So
Amazing.
it's
Such a big difference.
Yeah.
I remember being a junior radiographer, and if the person working with, if we haven't maybe seen that technique before, for a palliative patient, for example, having to send a patient home is one of the worst feelings.
Yes.
And then having to go back to the planning team and say, I need to do this straight away, please.
Yeah. And it hurts us because we're trying to win the battle for the patients, and that's what we're there for. And I know there's a difference between the US and Europe on scheduling, and we can probably get the replan done within 24 to 48 hours. I know some other cases it might take a week to 2 weeks to a month. So that's really painful. But it also puts strains on our clinic, because to get that replan done, we have to stop a plan that we're actually working on. So it causes delay. It causes like a ripple delay throughout. So that's unfortunate, but we're able to really avoid it. I think the number of replans we had this year is down by a significant amount, and the only replans we've done is because of body habitus, physical changes, weight loss, weight gain to the patient, stuff that is a little bit out of our control.
We've heard quite a lot about Cherenkov planning
Yep.
as part of this community conference. Can you talk us through that, and what's the impact been for you in your practice?
I think we were lucky enough to be part of the original beta testing for this, and I remember being in this conference last year. And I've been friends with Mike Dahlhammer for a while, and I know how excited
You're like
he
the
was.
dream team, aren't you?
Yeah.
You
Yeah.
both refer to each other so passionately in each of your talks.
Yeah.
It's great.
Yeah, we have a bit of a competition between Florida and Colorado, but I saw how excited he was, and I wouldn't say it's rare to see him excited about this, but he was really excited. And listening to his talk, we were really impressed. But you know, us, just like most people in this, we were saying, "Oh my God, we wish we could have it, but how are we going to get it?" And
Yeah.
then the opportunity came to us, and you know, we grabbed it. And as I showed in one of my slides, it was basically an immediate change it's an eye opener. The first patient we turned the cameras on, we noticed an issue. There was dose creeping into her axilla that shouldn't have been there. And then the second patient, we had contralateral breast dose that shouldn't have been there. So back-to-back cases on day one really opened all of our eyes from.
Did everyone freak out a little bit, going, "Oh my gosh"?
Well, for the first case, it was a bit more mild because the patient's been complaining about pain and or irritation in her armpit, but she doesn't speak English well. She's Spanish, so it was hard to understand. But so I said, "Oh, this is the first case. Let me look at the cumulative after treatment plan." And then I said, "Oh yeah, she's getting dosed there. That's why." But it was her last primary fraction, so there's nothing we can change. So then I went back to my office, and I barely sat down, and then I heard my name, basically yelling, "Hey, get over here, we need you to see this." So I ran. That was the second patient where mid-treatment they saw that the second field is basically, there's exodose or some radiation into the contralateral breast. So that's the one where we were like, okay, not only we can evaluate fraction by fraction at the end of each fraction, looking kind of at a cumulative projection or image or picture of what we delivered, we can actually make changes in real time.
Yeah.
And that's where kind of the positioning verification came, the bolus placement verification came, and all that stuff. So it's really revolutionized, I think, the way we all look at radiation oncology. And I think Mike probably said it, but we really think it's going to be standard of care one day. Because it doesn't give you all the information you can for all cases, but this is just the start. I'm sure they said the same thing about IMRT, years and years ago. I can't imagine what this would be like 5 years from now. It's going to be amazing.
Brilliant. Well, we always end Rad Chat with top tips. It's kind of our standard seal the deal at the end of the podcast episode. So for anyone out there who's thinking, "Oh, this sounds interesting, this is something we're going to look at in terms of implementation," what advice would you give them? What top tips would you share with them?
I mean, I was in their spot, I think 2017, 2018, where I had no idea what SGRT was all about. And I came to one of the first SGRT meetings in the US, and I was overwhelmed with information because you see the stuff Mike shows, the stuff that he's done, and you always think to yourself, wow, I'm never going to do that.
Yeah.
I'm never going to do a head and neck VMAT treatment with no mask and no immobilization. That is, that's Willy Wonka kind of stuff. But so baby steps, it's really, you have the team that brought you here. You have your therapist, radiographers, dosimetry physician. You all know how your workflows work. So kind of try to find a clinic that does the same things as kind of like you do, the same kind of body sites, or the same kind of workflows and all that uses SGRT, and go visit, go talk to them, go share your ideas. And that, I think, that is the biggest thing that helped us. a lot of our people were overwhelmed with what other people do because we were looking at academic centers and research centers and all these grandiose things, but starting small with, you know, prostate setups or prone setups or DIBH breast or whatever, and then just expanding from there. I think this is the best of what we learned, and you need a champion.
Yeah.
You need someone that believes, because if nobody believes in the technology, it's gonna, as we've seen in many other centers where it's just collecting dust in the ceiling.
Yeah.
So, you know, kind of like, you need a champion, somebody to help in every aspect of the level. So you need someone in with the radiographer, someone in physics, and they work together to kind of not push the product on people, but kind of make sure everybody understands the significance and how it can really, really help. So,
And there is an amazing community, isn't there,
Yes.
around
Yeah.
SGRT, which
Yeah.
is something we've definitely noticed.
and I try to add in any of my talks. The SGRT.org website is super helpful for people that just, you know, maybe more introverted or can't go on site visits because any other reason. All these talks that we give in all these conferences and more are all available for free online. So you just have to make an account and you can watch. You can just search for what you want. You want tattooless, you can find it, prone, supine, head and neck, anything, any usage of SGRT is there. So we have learned a lot from it. So if you're a more visual learner, that's your best guess.
Brilliant. Well, thank you very much for joining us on Rad Chat.
Thank you for having me.